On February 3rd, the Health Services Authority hosted a chronic care workshop as plans continue to strengthen chronic care locally. Director of Medical Services Dr. June Samuel gave an overview on the state of chronic care locally.
60% of our population is 21,000 persons now. Okay? Our youngest diabetic in our system, I think she's made 6 by now. Yes? Our average age of persons presenting with MIs, heart attacks, has been slowly decreasing. Dr. Wilson can bear me out. Our renal complications from diabetes and hypertension, more than 60% of the patients who are on dialysis, their end-stage renal disease is due to a combination of diabetes, hypertension, or a combination of both. And those numbers at our highest, we were at 54. And if these numbers don't worry you, here's one thing that worried me. We had an audit of our services that were being delivered to our hypertensive and diabetic patients done at 3 of our major clinics in 2013. And that audit showed that on some of the major indicators that we should be following with our patients, we were falling below target. So in foot inspections, less than 40% of our patients presenting who were diabetic had foot inspections done. For self-blood glucose monitoring, just about 25% of the patients were actively monitoring their blood glucose. For exercise advice, just about 25% of those patients received or had documented evidence that they received exercise advice. And that's just for the diabetes. I could go on about the hypertension. So I'm not sure what those numbers tell you. I'll leave that for you to come to your own conclusion. But financially, the cost associated with the delivery of services increases exponentially as higher and higher levels of interventions are needed to address the increasing number of persons who are presenting with complications of these conditions for care. We started with trying to provide dialysis services for 2 patients. Don't remember the exact year. We're now trying to provide dialysis services we're now about 49 or 50 patients. And we're asking for more chairs at an average of $3 million a year. Okay? Our lead cause of transfer for care is related to the need for cardiovascular interventions. And that was pre-NHI. Post-NHI, a year later, guess what's the leading cause of referral overseas for care? You should all shout it out. Cardiovascular services. Cardiovascular interventions remains the lead reason that we're referring persons overseas for care, and is followed very closely by the need for stroke interventions. And I don't have to tell you the sort of expense that comes with. All right? These conditions are occurring during individuals' most productive lifetime. So, do some calculations and think about it. And one of the things that I have been famous for saying is, when I get to 65, I would like to be able to collect Social Security. But if we continue at this rate, we are going to make a significant dent into our Social Security dollars, because that is what pays for the disability and the illness benefits associated with these conditions. So we have a significant financial drain as a result of chronic diseases. No health, no wealth, no social life. In the medical world, we have developed our services around, or we've seen a shift from acute communicable diseases being our major challenge to now chronic diseases being our major challenge, but the interventions for chronic disease fundamentally requires a different practice and a different approach to care. The practice of medicine has long been linear. Physician sits and waits for the patient, physician or nurse. The patient comes to us, we give them instructions, we send them away with instructions, we hope they're following the instructions, we sit and wait for them to come back to us, and if the instructions don't seem like they've been followed, we refer them to a few other people, we send them away. And then if we remember, we address the psychosocial pieces related to their not accessing care. That's linear. Okay? Even in primary care, where we would like to think we take a population approach to care, our health systems are traditionally shaped around acute care management and could not respond to non-communicable diseases, chronic diseases, which require active chronic care. The Global Health Strategy for the Prevention and Control of Non-Communicable Diseases indicates that NCDs can best be addressed by a combination of primary interventions targeting whole populations, by measures that target high-risk individuals, and by improved access to essential healthcare interventions for persons with chronic non-communicable diseases. Today at the BVI HSA, we re-begin the process of implementation of a model of care, the chronic care model, which is evidence-based and which moves our systems towards delivering high-quality chronic disease care management. The chronic care model is an organizational approach to caring for persons with chronic diseases, and it creates interactions between, I need you to remember these two things, an informed, active patient, activated patient, and a prepared, proactive practice team. Those are the two most important things for this model. Population-based approach to health, which in the BVI we have long recognized needs to happen. And one of the key elements was the requirement of persons being able to access care fully. So we solved that problem. We introduced NHI. And through NHI, all individuals have full access to this model of care. So that's one hurdle crossed. We need a prepared, proactive practice team. That's why you're here today. Today is your first step in preparation. We are all required, myself included, to examine our professional, personal values in the delivery of healthcare. And we are all going to be challenged to move towards an interactive, team-based approach to chronic care delivery. Today, we're going to ensure that our knowledge base is updated and standardized. Everyone will have the same information on which we're basing our clinical decisions, and we will all have access to the tools and resources to be able to deliver that care to our patients. We're going to become proactive. That requires us to intervene with the patient and not sit and wait for the patient. We will have to reach out to the patient. We would have to go and look for the patient. We will have to ensure that that patient at the center of the delivery of care is assisted in accessing all the necessary resources Those of us who work in community health, we're familiar with going to patients. But we need to apply that concept to the delivery of care for chronic diseases. It's not something we normally would do. Okay? And as a part of the multidisciplinary team, we're going to hear about the concept of the case manager and the case coordinator. And that is what that person will help us to do, make sure we always have the patient or aware of what they're doing. We're going to have informed, activated patients who get the information and they use that information to help us to manage them, not the other way around. Okay? They must use the information to help us to manage them. They must participate in their care. We want to engage them. Okay? And they must challenge us if necessary. So if they know that they're due to have their HbA1cs done every 6 months or 3 months, and it's not being done, they must be able to challenge us. We have to get our patients engaged and activated. That is one of the key elements to providing care for chronic diseases in the long term. We are building a system of healthcare delivery where the outcomes and the targets will say that we are providing safe, high-quality care, even in this area. Our commitment is demonstrated in the BVI Health Services Authority new strategic plan. It's in there. Okay? It is demonstrated in the active and visible leadership participation. We have our CEO here with us today, and I really have to say to her thanks, because since she hit the ground, she has taken on this project as if it's her own. And that's very important. I don't need to explain to y'all why, right? Because there's financial and other resources that will go into the delivery of this program. And the fact that the CEO is engaged says a lot about the importance that we're placing on this program. Our senior clinical leadership team, Dr. Segala, Dr. Wilson, Dr. Bovell, the nursing team, Nurse George and Nurse Lucy Martin, and Ms. Hodgpen. When you go and you read about the necessary tools for the chronic care model to be implemented effectively, it talks about the organization at the leadership level being engaged. We've engaged those leaders. And now today, we're here to engage you, all of the workers, all of our clinical care providers, because at the end of the day, you are going to be the ones who are going to deliver this care. It has to become our mantra, and we all must be saying the same thing all the time, every single time, and give that message to our patients. So today, it is an exciting day and time at the BVI HSA, and I wish you a very productive learning day today. Thank you.
Thank you so much, Dr. Samuel, for bringing it home to us, for making it real. When we listen and we look at our data in terms of what is happening in the BVI, I mean, even instead of talking about the region, it is always alarming. So we, in the health sector, we have to take a proactive stance. It's our responsibility. So again, thank you all for being here today. And a heartfelt thanks to the team, which comprised dedicated staff of the BVI HSA and the Ministry of Health. Please come and have a seat. Thank you for coming. And the Ministry of Health for staying the course and ensuring that the workshop, and by extension this program for enhanced chronic care management, is launched today. And it's always so important, sometimes a lot of things would happen in between, but we do have to remain focused. And what we are doing today really, at the end of the day, is not even extra work. It's about us redefining what we do in light of the information, in light of the statistics, and strategically making some overall organization-wide decisions. So workshops such as the one being held today, it is impressive. as it demonstrates the basis of what continuing medical education is all about, which serves for the following outcomes. 1, improved performance. 2, improved quality of healthcare delivery. And 3, improved patient and community health. And we would have heard from Dr. Samuel some key words, the words engaged, proactive. So it involves all of us. It involves us doing what we can to improve that service delivery and the outcomes that relates to patients and, of course, community health. And, of course, when we talk about population health, that is something down the road that we really have to focus on. So through programs like this, the data that's going to come from our chronic care program will better enable us to decide how we'll be using our limited resources. And when we talk resources, it's twofold, not just the money, but the human capital, us, to really make a dent in terms of the chronic care management. So based on the criteria established by the Accreditation Council for Continuing Medical Education, and I stress on this because we do a lot in terms of educating, our staff, ourselves as healthcare workers, but we need to take it one step further. So Dr. Samuel and I and the team, we are looking to ensure that our continuing medical education programs become accredited as well. Because today's workshop is, when I looked at the criteria, this is between 6 to 10 CMEs right here, just in terms of what we are doing today. All right. So looking at the criteria established by the Accreditation Council for Continuing Medical Education, it states that programs should be designed to change either the physicians, the nurses, the healthcare workers' competence, and that is what we are going to do, by teaching us strategies for translating new knowledge into action, or to change our performance in terms of what we actually do indeed practice, and more importantly, change the patient outcomes. Today's workshop is designed and intended to achieve just that, to enhance our competence, to enhance our practice in terms of treatment plans, and lastly, to enhance patient outcomes and quality of life. So I encourage you all to actively learn. I'm talking about active learning, there's a big difference, but to actively learn and put into practice the knowledge to be gained from today's workshop, as it will benefit you as well as those we serve or assist. There's an old Tibetan proverb that states, in terms of the secret of living well and longer, it says, eat half, walk double, laugh triple, and love without measure. So eat half, we know what the food, and walk double. So park up the hill and walk in. We all want to park right next to the door. Laugh triple. Laughter is always so good for the soul. There are some health clubs, I think, in Europe and the Tibetans, of course, where you just spend, if it's an hour or so, just laughing, because what? It comes almost as if you are running and jogging, isn't it? Plus, it gives you that mental well-being as well. So for us, remember that. Eat half, walk double, laugh triple, and most of all, love without measure. Unfortunately, these secrets are neither taught in our schools or are the way of life for most persons, and remain just that, a secret. Fortunately, the chronic care model that we are launching today identifies and promotes the use of the essential elements of a healthcare system that encourages high-quality chronic disease care and management. Now, the chronic care model, or CCM, is not new. It's not a new concept. There has been significant research conducted and findings published, and I brought some here today, on the benefits of the CCM that go back to the 1990s. In fact, I remember PAHO, WHO, and I would have been a little child, just a note, back in 1970 when it was held in Trinidad. And all countries came and they signed in terms of this charter, in terms of the promotion of chronic disease management and healthcare. So that was in 1970. In 1996, all the countries again, all of us from the region and elsewhere, went to Ottawa, Canada, and again signed another charter in terms of healthcare management and primary care and all of these in 2006. We all came together again. So what we are doing is not new, but I'm really thankful to the team for sticking the course and ensuring that we are indeed launching this program today. So we have a lot of information, a lot of research, a lot of publications that go back to the 1990s. So I encourage you, check the Journal of the American Medical Association, as well as the various Cochrane collaborations, those scholarly reviews. And you would see the accumulated evidence that supports the chronic care model as a very good framework to guide the practice of healthcare, as it will lead to improved patient care and better health outcomes. So just to give you a brief history of the CCM, and I actually took this extract from the 2009 Coleman research entitled Evidence on the Chronic Care Model in the New Millennium. The initial evidence upon which the CCM was based came from a review of interventions to improve care for various chronically ill populations. So this was across a cross-section of persons, different states, be it rural, be it urban, so different aspects of lifestyle. But again, looking at persons with chronically ill diseases and issues. These evaluations showed, and there was also a subsequent Cochrane collaboration review, which confirmed that multi-component practice changes in 4 categories led to the greatest improvements in health outcomes, namely increasing providers, and when we talk providers, we're talking all healthcare providers, expertise and skill, educating and supporting patients, making care delivery more team-based and planned, and these are all the words that Dr. Samuel were using, and 4, making better use of registry-based information systems. And these were the 4 changes that formed the basis of the chronic care model. So today, the CCM is a widely adopted approach to ambulatory care improvement. It guides quality improvement initiatives and is also an integral part of current patient-centered medical models. Until recently, evidence supporting the CCM was largely inferred from studies of its individual components. But over the last 20 years, evaluations, trials, and organizational effectiveness studies have examined and showed that changing ambulatory and primary care through the integrated set of practice changes that I just mentioned, which constitute the CCM, can improve patient care and lead to better health. And we do need better health here in the BVI. You know, I watch some of the young persons whenever I get a chance, to be outside. And I was looking at, there was a nice program looking at maybe some 10 to 12-year-old primary school children. I mean, I grew up a bit chubby. But back in my era, back in the 60s and 70s, if we had to do anything, we didn't walk. We used to run. Remember those days? We used to run. And we used to play. I remember being flogged to stop playing and come to eat because we were always so active. The schools, I don't know if they still have what we used to call recess back in the day. When recess was ended, I remember teachers saying, oh gosh, you all are smelling like a hog because you really enjoyed and took advantage of that 5 to 10 minutes or however long. But children today, I remember once being involved in a health promotion program because we looked at the young kids, and this is in Trinidad, and recognized in terms of the obesity factors, 12%, which was high. And when we went to the schools, I went with the nurses and the teams and the patient care coordinators and everyone, and we said, okay, let's have a little fun session. All those games that I grew up playing, from the moral to the hopscotch to the this to the that, we had to actually teach them how to do those things. And it's even worse now because everyone... I remember I was in Form 1, so I was about 11 years old. This is secondary school now. And I remember the teacher would have asked us, in the year 2000, start of the millennium, how old would you be? So I calculated I'll be 37. What would you be doing? What would you? And she showed us some studies, and there was a study that was done of course, there will be persons who would be promoting the use of technology, and there will be those who would note, oh my gosh, be careful because of the effects of. And this one study said that they could foresee that in time to come, the obesity factors would be out the roof, that our shape would change, and you are seeing it. He said there would be more fat deposits here. And I remember years ago knowing that the fat deposits here were for what? Pregnant, you know, because this is where you would carry the fat because you're breastfeeding and all this type of things. And that your fingers, these would eventually all become stubs because all they're using is just this. Right? And this was a study from, 1974, 75. And you're seeing it today when you watch the young persons, you know, their shape, right? So for us, this workshop is so important because we need to, and we have a responsibility to, and it's our mandate to ensure that our population is more educated. So there's a lot that the BVI say that we have to do, and we will do, in terms of educating the population, educating, you know, persons. And I know my mother, she had this motto, whether you want to hear what she has to say or not, our responsibility is to still say it. Because you know what's surprising? When you do get older, that's when you remember, you know, my mother did say, and granny did say, right? So again, learn, active learning today from this workshop. Dr. Samuel would have given us the chronic disease statistics for the BVI. It is no different to the rest of the world as well, which is why the WHO, the World Health Organization, not just adopted, but is actively promoting the chronic care model for all countries to sign off on and to establish. So chronic diseases are now, of course, the major cause of death and disability worldwide. It is responsible, and these are the same figures that Dr. Samuel indicated for us here. It is responsible for 60% of deaths, and more so, 50% of the global burden of disease. And when we talk about global burden, this is when the finances come in. So when we look at even our budget, our annual budget, a lot of it is spent, you know, and even with us supporting the NHI in terms of this alliance, is spent on helping persons improve their quality of life. And many times it is a bit too late when we, you know, when we look at things. We forget the impact of sugars and all of these things. Our teeth are supposed to last us what? Until you die. Your bones, your joints, your vision, your hearing, and all of these things are impacted by chronic diseases. And the lifestyle that we live, the sedentary lifestyle, the excessive sugars. How many of us, when we go to the grocery store, rarely read the labels? All right, so those are some of the key things as well that is important for us to teach our daughters, our nieces, any young person, you know, as you're walking in the grocery, you show them those are some key critical things, especially when it comes to diabetes management, how to read a label. So these are the things and some of the information that we will be passing on to our clients, our patients. So despite advances in the effectiveness of treatment, research shows that patients frequently do not get the care they want or even the care that they need. So the CCM, the chronic care model, is designed to help practices improve patient health outcomes by changing the routine delivery of care through interrelated system changes, which are meant to make patient-centered, evidence-based care easier to accomplish. The aim of the CCM and the aim of our CCM program is to transform the daily care for patients with chronic illnesses from acute and reactive to proactive, planned, and also population-based. It is designed to accomplish these goals through, and I would repeat what I would have said before, 1, a combination of effective team care and planned interactions. 2, self-management support bolstered by more effective use of community resources. 3, integrated decision support, and 4, use of patient registries and other supportive information technology. So these elements are designed to work together to strengthen the provider-patient relationship and improve our health outcomes. So for us in the BVI, given our rising healthcare costs related to increase in chronic diseases, it is imperative that we augment our practice and delivery of care to strengthen our doctor-patient and our nurse-patient interactions and relationships, thereby improving health outcomes and reducing the cost, the overall cost and the burden of care.
Thank you for tuning in to this edition of the GIS Report, where today we gave you some insight to what is being done in the area of chronic care towards a healthier Virgin Islands, one decision at a time. Reporting for the Ministry of Health and Social Development, I am Public Health Communications Specialist Natasha Latsum. Thank you for tuning in.